Hello, thank you for joining me today for this presentation titled Cognitive Memory and Communication Challenges Following Stroke. My name is Evan Page. I'm a licensed speech-language pathologist. I've been doing this for 25 years now. 23 of those years have been with health partners, mostly with Regions Hospital. But I've also done 2 stints of work at Methodist Hospital in St. Louis Park. And in fact, that was when I first learned about Inspire and all the great things that Inspire does. Now I'm currently with Health Partners Rehabilitation, but I'm very glad that Lynn asked me to do this talk today. I'm going to be sharing these slides with you. I hope you're able to see them okay. So I think we'll get started. And to advance. Okay, here is where I work currently. This is the Health Partners Neuroscience Center in St. Paul. We have a very full and busy therapy department here. And I work with a number of really great colleagues in both physical therapy, occupational therapy, and also acupuncture, as well as even recreational therapy. My disclosures, I'm an employee of Health Partners Rehabilitation. I receive a salary for my work. I'm not marketing any products specifically today. So just a little bit of a quote to get started. I know that if you're watching this presentation, either you or a loved one has probably experienced stroke. And I know that stroke is among the most affecting and terrible things that can happen to someone. So this is a quote by Jill Taylor, who wrote a book titled My Stroke of Insight. If you haven't seen this book, it's a really good one. Okay, the goals of today's talk first are to understand the levels of ability, disability, as well as principles of neuroplasticity. And I'll talk about why these are important. We're also going to understand how these things impact stroke recovery. We're going to identify common communication challenges and deficits after stroke. We're going to talk a little bit about how someone can communicate effectively with stroke survivors. And lastly, we're going to identify some of the adaptive or compensatory strategies for memory or cognitive challenges, some practical things that survivors or their care partners can use at home and in the community. One of the first things to know about stroke is, as you guys know, it is a very heterogeneous condition. So it affects a wide variety of things, and 2 people can have the same type of stroke, but yet have very different abilities and things they can't do. Okay. So here I'm probably preaching to the choir a little bit, but stroke, as we know, means a change in blood flow. And there are 3 basic types of stroke. They're the 2, what we call embolic strokes, either a thrombotic stroke or embolic stroke. These are caused by clots that either form in the arteries or that move up the arteries. And the other type of stroke is what's called a bleeding stroke or a hemorrhagic stroke. Okay. So when the brain doesn't receive the oxygen it needs, brain cells get damaged or die. If this happens, you might lose control of your arm or a lot of other things. So again, it's basically a change in blood supply to the brain. Okay. Of all the body organs and muscle systems, the brain requires and utilizes the most energy and the most oxygen. Okay. It requires a continuous supply of this oxygen from the bloodstream. And when that blood supply is interrupted in some fashion, the nerve cells in that area or in adjacent areas can be damaged and can die. Um, Stroke affects nearly all the major things the brain does for you. This includes processing information from your senses, listening, speaking, planning, thinking, and even swallowing. So the brain has four major arteries that provide blood from your heart. They're the two carotid arteries in front here in your neck, as well as the two vertebral arteries in the back of your head. Um, what can be affected in stroke? We've covered some of these: movement, the ability to walk or complete daily activities, sensation, feeling, vision, balance, speech, language and speaking, listening and understanding, reading and writing, and even swallowing. We know that over 15 million people experience a stroke in a year. Um, of these, at least half experience a significant amount of disability. Although that number, the number of persons with disability after a stroke, actually has been steadily declining in recent years. So, so now I'm going to pose a question to you. Um, did you have therapy, either physical therapy, occupational therapy, recreational therapy, or speech therapy after your stroke? And if you did, just raise your hand. I imagine most of the people who are watching this will be raising their hands. If you did and you found this was helpful, um, the therapy was likely uh, a product of what I'm going to talk about next, which is called the ICF, or the International Classification of Functioning. Um, the ICF is a framework that was developed by the World Health Organization, or WHO, to organize and conceptualize information about health and disability. Because we know that stroke is one of the leading causes of disability. It provides a standard language and conceptual basis for the definition and measurement of disability. So it talks about bodily functions and structure. It talks about the activities that an individual participates in. It also discusses the level of participation or the degree of participation of the individual in a life situation. And it also has additional information on severity and environmental factors. It's now about 20 years old. It's an old document, but still a very good and important document. The ICF, when it came out, was a paradigm shift from the way we used to think about health and disability to the way we do now. Okay. We used to think of the two as very separate things. Um, but what ICF showed us is that really anyone can have, for a variety of reasons, a loss of health or functioning and experience disability. This can either be temporary or permanent. The ICF recognizes that there are multiple avenues for delivery of services to those affected by stroke. And it recognizes that reductions in the incidence or the severity of disability in a population can occur by either increasing the individual's or person's functional capability or capacity, or by reducing the societal or environmental barriers to participation. So if you think about the disability numbers I mentioned earlier, The ways to decrease the occurrence of disability are either to increase the person's functional capability, i.e., what they can do through therapy, or to decrease the barriers to participation, whether they be in the workplace or in the community. So, um, under the ICF, disability is always an interaction between the features of the person affected and features of the context or society in which that person lives. This exists on a continuum. Disability is a universal human experience. Functioning and disability are viewed as a complex dynamic entity, emphasizing the interaction between or among a patient's health and condition, that individual's degree of participation in activities, contextual variables such as their level of education, their coping style, their life experience. All of these things influence how disability is experienced by the person. And as I said earlier, this had a profound impact or effect on disability policy in nearly every rehabilitation center in countries around the world. Okay. So imagine if you, for example, if you had a stroke and had weakness on one side of your body, and let's say you had to use a wheelchair. Okay. If you lived in a community where everyone used a wheelchair, okay, um, you might not experience much disability because your condition would not be that different from the condition of the others with whom you interact. However, if you have a stroke and need a wheelchair, and you're the only person in your small town um, who uses a wheelchair, and if many of the stores and buildings in town are not that accessible in terms of um, amenable to using a wheelchair, you would definitely experience more disability. Okay. The ICF has implications or applications at many different levels. So at the level of the individual or the stroke participant, um, we might ask what happened to cause their disability. In this case, it would be stroke. What we might ask, what was the individual's level of functioning, both before and after the stroke? What treatments, particularly therapies or interventions, can maximize their functioning? We might ask, what are the expected outcomes of these treatments and how useful were the interventions? And then how would the survivor with stroke self-rate problem areas such as community or communication, mobility, or self-care? Okay. We can next talk about applications at the level of the institution, such as the hospital or the rehabilitation facility. What healthcare services will be needed? What frequency and intensity are appropriate? What is the evidence base for these decisions? What are our indicators for quality assurance? How well do we serve our clients? How useful are the interventions? And lastly, how cost effective are they? Okay. Okay. And then lastly, there are applications at the societal level. What are the needs of the disability or the disabled as a group? How can we modify the social and physical environment to improve access for all? Are the criteria for eligibility for disability benefits evidence-based? Are they appropriate and justifiable to social goals? And will improving access and guaranteeing rights improve the status of the disabled as a group? Can we adjust policy and law decisions appropriately? So now I'm going to actually shift topics. This is the next topic in our talk. This topic is neuroplasticity. What is it and why does it matter for stroke survivors? Neuroplasticity is a relatively recent discovery about the nervous system, let's say in the last 30 to 40 to even 50 years. Um, it's about how the nervous system repairs and renews itself following an injury, such as a stroke. Clinically, neuroplasticity is how the brain reorganizes itself following an event. But practically, it's something that is always going on, even in people who haven't had a stroke. It is the ability of the nervous system and the brain to change its activity in response to internal or external stimuli by reorganizing its structure, its functions, or its connections. It has two components, what we call neuronal regrowth, often referred to as regeneration or sprouting, and then functional reorganization. There are three terms here. There's equipotentiality, vicariation, and diathesis. So one of the first terms about neuroplasticity is this concept of sprouting. And this is one of the most novel things because we used to think that people were born with a certain number of brain cells. And when those brain cells died, you kind of lost them throughout the extent of your life, and that people never ever gained new ones. We now know that's not true. So this concept is called sprouting. I really actually love this term. Okay. It is the process of adding or growing new neuronal connections in an area of the brain. It happens when existing neurons, nerve cells, branch out and connect or make connections with other cells, creating essentially a wider or a thicker wire. Okay. So the example that I'm going to cite for this is if you think many, many years ago, before the concept of Google Maps and before Uber and Lyft, if you lived in the city of London in the UK and you wanted to become a taxi driver, a cabbie, um, you had to pass this very extensive test called the knowledge. What this basically is, you had to know, without referencing any sort of book or looking at a map or anything like that, you had to know how to get essentially from anywhere in the city of London to anywhere else. Okay. So what this researcher named Eleanor McGuire did is she looked at the brains of London cabbies, these people who had for a really long time practiced and learned everything about the geography of London and where things were. Okay. So they looked at the gray matter in an area of the brain around sort of in the midbrain area called the hippocampus, okay, where a lot of memories are stored. Okay. And she noted that essentially this area was much more developed from a wiring standpoint. Okay. And then she compared those with the brains of just people who weren't taxi drivers. And she noted that there was a very significant bulkiness to this part of the brain in these people who had passed this test called the knowledge. Okay. So this is sort of a landmark study that sort of established that this concept of sprouting exists. Some other neuroplasticity key concepts are equipotentiality and vicariation. Um, Now, 100 to 150 years ago, the initial scientists who studied the brain didn't have CT scans or neuroimaging or any of the tools that we have nowadays. The only way they could study the brain was to notice that somebody had a problem. So they did a lot of study initially with people who had strokes, because often those people had paralysis. So they knew what part of the brain was affected by the stroke. And then when those people died, they did autopsies and they looked at the brains to see what part was damaged. So this led to the early theories about the brain, which were heavily based on the concept of localization. So we used to think that like each part of the brain controlled one certain thing. So, and we know that to some extent this is true. Like there's a part of your brain that controls your right hand. That's true for most people, regardless of whether you're right-handed or left-handed. Um, so this is the idea of localization. But as we've as we've developed newer tests and imaging studies that can look functionally at how the brain works, we know that localization is not the only answer, that the brain is much more interconnected and dynamic than we thought. And yes, there are areas that are responsible for different things, but those areas are also dependent upon the rest of the brain working to be able to control things. So this idea of equipotentiality is the idea that different regions or different parts of the brain are sort of functionally equivalent. So this suggests that other parts of the brain that might not control something like the hand can be rewired to take over some of the functions of a damaged part. Okay. Okay. And that's what this second concept is, vicariation. It's the process of one part um, assuming the functions of a damaged part. And this concept actually has been documented in studies, for example, in monkeys and other animals in scientific studies. Okay. Um, Another neuroplasticity concept is the concept of diathesis. Um, this means shock throughout. So this was what sort of led us to revise the initial localization theories of the brain. Um, we knew even when we did those initial studies that localization didn't explain everything. So many people who had stroke had unexplained problems or behaviors that weren't explained by the damage in the part of the brain that was shown to be damaged. So we always had trouble explaining this. So what diathesis is it's basically a change in a portion of the brain that's distant or far away from the area that was actually affected by the stroke. And the way we explain this now is that really the neurons and the cells in the brain are much more interconnected than we originally thought. Okay. So this term has been originally was sort of a pejorative term, it had a negative connotation. Um, but now it's recently sort of taken on more of a positive connotation in the context of neuroplasticity. So it does explain previously unexplained behaviors that we see in stroke survivors. So neuroplasticity, but one thing I like about it is that it has such practical applications for recovery. So there are five basic principles of neuroplasticity that have a lot to do with educational theory and learning, okay? Because it basically explains how people can learn and also how people can rewire or acquire previous skills after brain damage or after a stroke. So the first principle of neuroplasticity is we call it use it or lose it. Um, this principle states that ideas, skills or concepts that are not regularly practiced become harder more effortful, or less accurate over time. So the classic example here is, for example, when you were young, maybe you learned a musical instrument. So that might have been in high school, you played trumpet or something like that. But let's say after high school, you stopped practicing and you now haven't touched the trumpet for 20 or 30 years. If I handed you a trumpet and asked you to play something, I guarantee that you couldn't play as well as you did, when you were in high school. And that's simply because you're out of skill or out of practice. Okay. Um, so this this has obvious implications for a lot of complex activities, such as speaking a foreign language or doing a very complex activity like chess. Okay. Um, the next principle of neuroplasticity, this is really important. It's called use it to and improve it. Okay. Um, what we know is that many motor and also cognitive tasks become easier, more familiar, faster to perform, and we might say more accurate when someone has practiced or completed them numerous times. Good examples there would be an activity like ballroom dancing or golf. You know, in order to get your golf game up, you really have to practice it a lot. Okay. So we know that the more you practice something, the better it gets. So that's what that use it and improve it concept is. Okay. The third principle, what we call novelty. Okay. Um, Novelty means something new or unfamiliar. Okay. So your brain actually likes things that are new. Your brain feels challenged by things that are new. So we know that people actually do a better job of learning things if it's new or unfamiliar, as opposed to something that maybe is old or, you know, not that interesting. Okay. Um, and it's even better if the activity that you have to learn is somewhat complex. Okay. Um, the next principle, which is closely related to principle number 2, is that intensity matters. Okay. The only way your brain is going to rewire itself or do that sprouting or establish those new connections is if you work at a certain level of intensity. So there's a threshold. So for any activity, let's say if I'm working, for example, I'm a violinist. Let's say if I'm studying a new piece and I'm trying to learn a new piece. In order to do that, I have to practice for a certain degree of time or a certain number of repetitions. Okay. Once I do that, that will help to strengthen those and make those connections that I need to be able to learn that music. If I don't practice that frequently, those connections are not going to get made and I'm not going to learn this. Okay. So this note here is actually from a talk that I gave to speech therapists. This talks about why we really need to assign homework in therapy. Okay. All right. The last principle of neuroplasticity is that salience matters. So this is kind of closely related to novelty. Okay. Um, excuse the note here. I didn't realize that these notes were going to be displayed here during this talk. Um, so salience or prominence refers to the interest level of activity. Okay. So we know from psychological research that if something you're learning or trying to do is inherently motivating or interesting to you, you're going to learn it better, or you're going to acquire it better. Okay. So, okay. So the next slide is implications of neuroplasticity for stroke recovery. Okay. Um, First thing I'll say is that recovery is real. We know it happens, regardless of your stroke onset, when it happened, your stroke severity. Um, we know that recovery after a stroke happens on the brain's timetable, not necessarily your timetable or even society's timetable. We know that recovery rate, or how much recovery you get after a stroke, may be influenced either positively or negatively by other factors that are both external or extrinsic, um, and internal or intrinsic to the stroke survivor. Okay, so these would be things like your coping style. This would be like the amount of adversity or difficult things you've had to endure in your life. Um, Other factors such as your access or the availability of rehabilitation. So all these things can positively, or their absence of them can negatively affect stroke recovery. Okay. Um, we also know that recovery from stroke tends to be the strongest in the first months to a year afterwards, but we know now that recovery can happen even later, even beyond a year. We know that recovery slows a little bit after that time, but it still has been documented. Okay. So now we're going to talk a little bit, new topic, we're going to talk about communication. Okay. Because communication is one of those things that's affected by stroke. Okay. So what is communication? Communication is how an individual exchanges information with others through a socially shared or understood group of symbols or language. Information can be feelings, needs, desires, plans, opinions, or facts. Communication is a very broad concept. It includes verbal communication, nonverbal communication, and body language modes. It exists in humans and it exists in animals, and it also exists at many different levels or planes sort of simultaneously. We generally think that communication requires a sender, a message, and a receiver. And thus, there is an action of intent, of expression, and also an action of understanding or receipt or comprehension. Again, this happens with many different layers, literal, direct, or even implied or figurative. Okay. You've heard of the analogy of a two-way street. That's what communication is. It generally requires a shared sort of, we call it a frame of reference or a subject base, um, for it to happen successfully. There are many different forms of communication or expression. These would include movement, gestures, objects, posing or postures, vocalizations, verbalizations, speech, signs, pictures, symbols, printed words, or even speech that is synthesized, produced by a computer. Um, in terms of human communication, we typically think of verbal and written forms as the most effective types. Um, and good communication requires willingness and intent from both, or in the case of more than two, all of the communication partners. And this is really important. Um, Communication is often affected by stroke. So it often means that the communication partner or the family member or the friend or the, the partner of the stroke survivor may have to do sort of more work or assume more responsibility for the success of the communicative interaction. So we'll talk a lot about this later. Okay. Again, communication requires sustained attention. It requires awareness on the part of the partner of the speaker's need to communicate or desire to communicate. And it requires self-monitoring by all the parties, both the speaker and the listener, regarding whether the message was conceived and perceived, understood. So there are many different ways a stroke can affect communication. Um, uh, so some of these are very specific to stroke, and some of them are more general. Okay. The first one we'll call dysarthria. Dysarthria is a problem of speech production. It's basically, we call it slurred speech. So sometimes in stroke, the muscles in the mouth, particularly in the tongue, maybe in the jaw, in the soft palate, in the larynx, don't work as well, or they're not as precise. So when that happens, it's harder to produce a lot of the specific sounds of speech. So that can cause distortion in a person's speech. It's we call it a motor speech problem because it arises from weakness in the actual muscles themselves. Okay. Um, Oftentimes, with uh, a lot of strokes, dysarthria tends to be prevalent right after the stroke, but it tends to improve spontaneously over time and with therapy. Um, so it is a little bit rare for someone to be severely dysarthric for super long after a stroke, but it can happen. The other thing is what we call apraxia of speech. Um, it's similar to dysarthria, but this is a problem not so much of the weakness of the muscles, but in the electrical signals or the motor sequencing of those muscles or movements. So this is more of a brain phenomenon than a muscle phenomenon. Okay. So with apraxia of speech, a speaker may mispronounce sounds or have trouble sequencing the sounds. They may have a lot of false starts. They may sort of grope to try to produce sounds. Okay. Um, their output sounds kind of distorted and different and odd. So in that sense, it's sort of similar to dysarthria. Okay. Um, the next thing we call aphasia. Okay. So aphasia is a language-based problem from stroke. Okay. This is occurs in anywhere from 10 to 20% of people who have stroke. It typically occurs with damage on the left side of the brain, particularly in an area called Broca's area or in the left temporal lobe. Um, it tends to be most prevalent in people who are right-handed. Okay. So aphasia is trouble with listening, speaking, reading, or writing. Okay. So this is, instead of it being a speech problem, it really is a conceptual or a language problem. People with aphasia know what they want to say, but they can't get it out. Okay. Um, the problem can range from mild to severe. Often it's severe enough that it it significantly impairs a person's ability to complete many daily activity tasks, such as, for example, ordering food at a restaurant. Okay. Uh, then, even when somebody doesn't have a left-sided stroke, they may still have some aspects of the stroke that affect communication. So often, even when someone has a stroke somewhere else in the brain, they may have a lot of word finding trouble. They may have what we call slowness of word or lexical retrieval. Okay. So if you think about the normal rate with which someone talks is about 150 words per minute. Um, so with slowness of lexical retrieval, what happens is your brain can't supply the words you're thinking of fast enough to keep up with that usual rate of speaking that you have. So what that leads to is pauses or hesitations as you wait to try to think of the words you want to say. Okay. So when people have this, we don't usually characterize it as aphasia, but it's still something that other people notice. It's still limiting in terms of communication. So this another word for this would be kind of we call it the tip of tongue phenomenon, where they can't think of a word fast enough to be able to say it in a sentence. Okay. And lastly, there are other problems that we call cognitive communicative difficulty. Okay. This is difficulty sequencing or organizing what you want to say. So people with this difficulty have trouble staying on topic. They have trouble focusing. They have trouble sort of completing or finishing what they were starting to say. And they may shift topics randomly without sort of preparing or letting people know. Okay. So this is something we see with a lot of different strokes, particularly strokes that involve the right side of the brain. So, and I apologize again for the notes on the right side of the screen. I didn't think that I just copied a bunch of slides when I made this PowerPoint, and I didn't think that those notes would be visible. So tips for communicating with stroke survivors. The first thing to remember is that the problems that someone has with communicating after a stroke are not that different from the problems that ordinary people have when they're stressed or tired. Okay, so all persons have good days and bad days. Okay, and they may have variable success with communication on their bad days or not so good days. Okay, and this is even true for people with aphasia. The problems that people with aphasia have may also, anybody can have those types of problems depending upon what's going on in their life. So there are many tips that can help stroke survivors communicate better. So a lot of these are things that their communicative partners will have to do. So the first thing is to hear and be heard. So do whatever you can to reduce the level of background noise so that either the communicative partner or the stroke survivor can hear and understand you. Okay. Um, so reduce the level of background noise in the environment or move to a quieter location. Um, be sure that the communicative partner or the stroke survivor can see your face. A lot of us get visual information from speech to a higher degree than we think. And so this helps us, or this augments our comprehension of what's being said. Okay. Um, if you need to face the person directly, that's often helpful. Don't talk to someone from a different room or don't talk with your back turned. Okay. Only one person should speak at a time. And then assistive devices such as hearing aids, personal amplifiers are also helpful. Another set of tips is to be understood. Okay. Um, when you're communicating with someone who's had a stroke, it's good to use a slower, more deliberate speech rate, but don't do this in a way that's condescending or pandering. Um, it is helpful to use shorter, less complex sentences. So maybe simple sentences, like with a subject and a verb. Um, it's good to speak in a slightly louder voice, but don't shout. And actually don't exaggerate mouth movements. That tends to make things worse. And this is something that this next thing is something that I'm trying to model here. It's a good idea to explain or indicate when you're changing a communicative topic. I've tried to do that every time I've changed subjects in this presentation, because that's one of the things that stroke survivors report is the most difficult thing after a stroke, is that sometimes they don't perceive when someone has moved on or changed topics. And that's also what the communicative partners of stroke survivors will often say, because sometimes it's hard to tell when we move from one topic to another topic. So try to be more deliberate about this when you do change a topic, like maybe even announce it. Okay. The next set of tips is agree to understand. Okay. Um, you and your communicative partner should give each other more obvious and direct feedback about the success of the interaction. Remember how I said earlier that communication is a two-way street. Um, so you could say something like, be sure to speak up if you didn't understand or if you're vague. So say, could you repeat that? I didn't get that. You could also repeat part of what the person said just to kind of verify the subject or the topic. So verify the information and say, I think I heard you say that the party is this Friday at 8. Am I right? Okay. Um, you can also use written notes to verify things. Ask yes or no questions. Those are all helpful. And the last set of tips is be an equal. Understand that you have an active role to play in the success of any communicative interaction. Be present and engaged. Be patient. Okay. Use gestures and eye contact to show that you're listening and that you're available. Okay. Um, Always talk directly to either the communicative partner or the stroke survivor. If an interpreter is being used, don't talk directly at or to the interpreter. Okay. Um, if you think you know the word that a stroke survivor is trying to generate, give them hints in the form of either, I think the word you're trying to think of starts with a letter H. Okay. Or you could even give them the first couple sounds. We call this phonemic cueing. So you could say it sounds like ha. Okay. If you're going to think of hot dog. Okay. Um, Most people with aphasia from a stroke can communicate if given extra time and patience and assurance. All right, so now we're going to change topics again. Okay, now we're going to talk a little bit about cognitive loss following a stroke. Okay. Cognition loss following a stroke is a very common occurrence, especially if the stroke occurs in the cerebral cortex, the upper part of the brain, um, uh, or in the sort of the central part of the midbrain, an area we call the basal ganglia. Okay. Um, there are a few stroke types that don't typically affect cognition. These are mainly strokes that happen either in the brainstem or back in the very visual cortex of the brain. This is a small number of the total strokes that happen each year. So when we're talking about cognitive loss, this typically involves changes to memory, one's ability to process information, their attention, or their what we call their executive skills. Attention. This is something that everybody has. It's something that facilitates or enables us to use memory. Okay. It's a highly complex ability. It ranges from the simplest type, which is just basic wakefulness, all the way to the most complex and demanding type, which is when you're dividing your attention. It's often affected by all types of acquired brain injury, including stroke. Okay. And it requires sensory abilities such as hearing, vision, smell, and touch. Memory loss. Okay. This occurs because of involvement of the hippocampus or related structures and their pathways. Um, we generally talk about two broad types of memory. There's what we call long-term memories and short-term memories or working memories. So memory loss after a stroke usually affects someone's short-term or working memory. Okay. Um, it may involve one or both of the core memory skills, which we call encoding and retrieval. Encoding is the process of kind of getting the information into your head, and retrieval is the process of finding that information when it's time to remember it. It may also involve a loss of ability to remember, to initiate or do things in the future. This is something we call prospective memory. As I said before, there's a close and very interdependent relationship between memory and attention skills. So, one thing you often ask when we forget something is, why didn't I remember that? Okay. Um, Lots of different explanations for that. It could have been that at the time that you were told something, you were distracted at that time. This distraction prevented your brain from sort of storing or recognizing the information. Okay. The other possibility is that you might be having trouble retrieving, even if you were exposed to the subject or the topic, and you did store it, you might be have trouble retrieving this information. Um, okay. If you didn't remember something and then someone says to you, "Did you want to remember Sarah's anniversary on Thursday?" And then you go, "Oh, that's right." Okay. Then we know that you did, in fact, um, store it okay, but you didn't retrieve the information okay. And one of the advantages of the tests that we have that look at memory can tell us which of these two processes, storing, encoding, or retrieving, is affected. Um, we generally think that when someone has an encoding or a storing problem, that those kinds of problems are typically more aligned with more severe memory problems, whereas retrieval functions tend to be generally milder in severity. Okay. So now let's talk about some of the adaptive slash compensatory strategies for memory and attention. Um, so when someone has memory loss, there are several things that can help them. More and more things every day, in fact. So when we talk about strategies, we kind of characterize these two ways. We can talk about internal strategies, and then we can talk about external strategies. Internal strategies are the things that you, as someone with memory loss, do to increase the chance of you remembering something when it's time to remember it. Okay. External strategies are things either in your environment or they are objects, prompts, or alerts that help to increase your chance of remembering something. Um, the first thing when we talk about these strategies, we should say is that everybody likes to multitask. Multitasking as a concept is really overrated. It's much better to try to focus on doing one thing at a time well than it is to attempt to multitask and not do well. Okay. So basically, if you are doing something that involves reading, please turn off the TV or the radio, mute your cell phone, select a quiet place in which you're going to do the task. If you're doing something that involves more listening, then be sure that you don't have a lot visually going on that's going to distract you. So then we talk about the internal memory strategies. Um, these harken back to kind of what we learned about neuroplasticity, repetition rehearsal. So if you are learning something and you repeat it over and over to yourself, the more you repeat it, the better the chance of that storage or that encoding happen. So saying something to yourself multiple times, rehearsal, improves the odds of you remembering something. And then that other principle of neuroplasticity, salience, also matters. You're more likely to remember something if it has an inherent amount of interest or meaning to you. Some other internal strategies are things like association. With association, you group things together so that you're trying to remember one thing instead of six different things. Okay. For example, this is a good example here is making a shopping list. Okay. So if you had a bunch of different dairy products, such as cheese, milk, and yogurt, if you conceptualize those as dairy, okay, it's easier to remember those three different things when they're sort of subsumed under that category of dairy things. Okay. Um, this next strategy is sort of, we call it mnemonic strategy, which is where you try to create a word of the letters of the things in the list. I actually discount this a little bit because it requires more what we call executive skills than it often does to just remember the list in the first place. So next we can talk about the external strategies for memory and attention. Okay. Um, so, um, so these are the things in your environment that help you remember things. So the first sort of rule or principle here is the idea of consistency. Okay. If after a stroke you are misplacing things or you're losing, you're more forgetful, everything that is yours that you use on a typical day should have a place or what we call a home. Okay. So be sure that every day when you're not attached to these things, that you put them in this same place or this home every day. So, for example, I put my wallet in this cubby by the back door. And as soon as I come in the house, that's where I put it. And when I leave the house, that's what I reach for. Okay. So everything that's important, like your phone, your wallet, your purse, your keys, should all go in the same place. And it should be somewhere that's sort of like near your door or someplace where you're going to remember to look for it. Okay. A lot of the other external strategies are things like planners or calendars. Again, writing things down, keeping written lists will increase the chance of you remembering something. Things like sticky notes are okay. The key with sticky notes is be sure to manage them. Like if you've got a desk that's just papered with sticky notes all over the place, or you've got sticky notes all over your kitchen cabinets, um, they can very easily become overwhelming. So if you use sticky notes, be sure to manage them. And as soon as you're done with a sticky note, throw it away. Okay. Um, Things like pill boxes can help you keep track of your medications and whether you've taken them. And I can't say enough about smart devices. Okay. One thing that, I've discovered recently is these things called Bluetooth trackers. So this would be like an Apple AirTag or AirTag or a Samsung Smart Tag. So these are little electronic devices that you can just attach. You can put it on your key ring. They even have a card that you can put in your wallet. I even have an AirTag on my cat. Okay. So these are small little electric devices, and you can use them to track where things are. So if you're more misplaceful after a stroke, you can keep track of things and not lose them. Okay. Um, Again, smart devices, even your cell phone, if you use the calendar and the appointment function in your calendar and set smart alerts so that your phone chirps or rings when it's time to do something, that really has helped many people be more independent and not forget as much. Um, um, Devices such as like the Alexa device, they have an Echo Show that has a screen. It can interact with you. You can program it to remind you for things. It can call out to you in your apartment or your house. Um, you can coordinate your personal calendar with those of other people in your family. These are devices, calendars or apps called Cozy is one, FamCal is another, where someone else in your family can see your schedule or your therapy appointments and you can see theirs. Um, just helps to sort of coordinate among the family. Um, and then if you're driving or if you're navigating, GPS apps such as Google Maps can give you audible turn-by-turn directions for where to go someplace. So I know a lot of people who are stroke survivors who, when they go back to driving, even when they go to familiar locations, they still put it into Google Maps and use GPS um, just to be safe. Okay, just to be sure. Okay, so that actually is the end of my presentation. I hope you've enjoyed it. Please reach out to me if you have any questions. Again, I'm at the Neuroscience Center here in St. Paul. Um, Thank you for watching. I hope you've enjoyed this.